Hi, thank you for asking me to talk, George. It's a real pleasure to be here. Lots of familiar faces in the audience. Right, let's see if I can... Fantastic. I've just added a little subtitle here, which is what happens to me in clinic a lot of the time, which is I say to the patient, so how are you getting on? And the patient says in good Birmingham speak, oh, I'm all right, Bab. And the spouse or the relative is in the corner, just sobbing gently to themselves, partly because they daren't say anything because they know they're going to get it in the neck in the car on the way home if they talk about anything. So usually what happens then is somebody goes to test the patient's gait for a little walk round or to weigh them or something, and then you can have a little chat with the spouse and find out what's really going on. This is important because it illustrates quite a lot about the types of abnormal mental states people with HD get, and also what might be going on in the brain, which I hope to talk to you about. Just a couple of plugs before I get started. This is where I work in Birmingham. We see a bunch of things that sort of fall in between neurology and psychiatry, and Huntington's is a good example of that. It's an example of a condition that doesn't really need either neurologists or psychiatrists. It probably needs Huntingtonologists who know a bit of both, and hopefully I'll show you the brain reason behind that in a couple of minutes. We also run a course in Birmingham for clinicians like yourself, which is in a range, it's clinical neuropsychiatry, so that includes Huntington's, epilepsy, head injury, but the psychiatric and behavioural aspects of that. And it's half a day a week over 2 years, and there are a couple of ex-students I can see in the audience. If you're interested in that, there's a little email there. Okay, on to the talk. So I'm going to really talk a little bit about what changes in the brain, but you've done a lot of that in the last few minutes, I think, but specifically to do with abnormal mental states. I'm going to digress very slightly in the middle and talk about how, because it falls between neurology and psychiatry, how we can get the diagnosis wrong, and in my experience, clinical experience, the times in which that's happened, and some of the pitfalls that we can avoid. I'm also aware of overlapping a little bit with David's talk this morning, but I've got a little bit of new data to talk about how common mental disorders are, and my ideas about what are the brain reasons why people might get mental disorders of different kinds, particularly these ones, depression, irritability, apathy, and mental inflexibility. And if we've got time, I could talk about what could psychiatric services do about that. On this last case, I'd just like to have a quick show of hands from people. Hands up all those who nursed people with or looked after people with Huntington's disease in old Victorian asylums. There's a little cluster there. Every time I do this talk, it gets fewer and fewer. There was a time when people with Huntington's disease used to get looked after as a matter of course within the mental health system in the old asylums. And a weird thing that's happened, when the asylum closed, these people just sort of got kicked out of the system totally and sort of written out of the script. It's a strange thing that's happened. But if we've got time at the end, which we probably won't, I'm going to talk about that. Okay, here's a brain. Fantastic. On this side here, we've got a relatively normal but dead brain. And on the left side, we've got a brain for someone with Huntington's disease. And for those of you who like anatomy, here's some little bits of brain. This is a bit Sarah was talking about, the caudate nucleus. I'm afraid this pointer isn't very good, so I'll just show you that. There's the caudate nucleus. Most of Sarah's slides were sagittal slides, so from one side, or axial slides, looking from the top. This is coronal, so it's looking from the front, what I call the slice bread section. And you can see where the caudate nucleus, it sort of bulges out in the ventricle. In this very severe HD brain, you can see how it's really become virtually non-existent. So it's this bit of brain we're interested in, the striatum, and what it does, because that's the bit that goes. You can also see from this brain, actually it's not just the caudate, it's not just the striatum, it's the whole brain. And in fact, if you think the Huntington protein affects all cells in the body from conception, so the miracle is how long cells all over the body survive with this abnormal protein. Just so happens that cells in the caudate are particularly vulnerable. It still takes quite a long time for them to show functional effects. Okay. Here's a similar way of looking at this. This is an axial section looking at glucose metabolism, and on the far side away from me is the HD brain and then the normal brain. You see these bits here. This is effectively the striatum, again, the caudate nucleus. You can see how actively metabolizing it is in a normal brain. and how you can hardly see it in the HD brain. So structurally and functionally, the caudate, the striatum, is not working. I think you've got that message. Right, here's another way of looking at it. This is a monkey brain. This is again a coronal section, so looking from the front. Now, when I was a medical student, which was a very long time ago in the 1980s, I was taught that this bit of brain here did motor things and nothing else. And that all the emotional things, the cognitive things, we didn't really think much about cognition in those days, they all lived somewhere else, which was called the limbic system. And it had nothing to do with the striatum at all. The striatum was purely a motor thing. Then in about 1986, which was I was in the middle of medical school, but we didn't get to hear about it then, some people called Alexander and DeLong wrote a paper saying, actually, in the striatum, it does motor things, it does cognitive things, and it may also do some emotional mood regulation sort of things, but they're all completely separate. They don't mix up with each other. And then here's a nice little slide in a monkey brain, so not necessarily a human brain, where they've got these bits of brain. So they've got the sensory motor bit, that's in the pink. They've got the executive bit, that's sort of organising, planning bit, that's in yellow. And the limbic bit, that's more like the mood bit, and that's in orange. And I think you can see from this, although there are discrete areas, which are motor or emotor or cognitive, actually, in terms of anatomy, it's all mushed up together. So actually, I have a theory about this, which is when we talk about these areas, it doesn't really represent a wonderful sort of anatomical distinction, a discrete distinction. It might just reflect the sorts of professions that are involved in the care of people. So this bit is just like the psychologist's brain, this is like the psychiatrist's brain, and this is like the neurologist's brain. And actually, we're just interested in those bits separately. And that doesn't seem to make any sense to me. So if you look at this anatomically, you don't want three different professions. You want one striatomologist, really, who can look at it all and put it all together. Oh, I'm missing a slide. Never mind. Okay. Right. I'll just stay on this slide for a second longer then in that case. What we also see, if we go to look at the cortex, the way these areas are represented in the cortex, for instance, sensory motor, we know is like the motor strip and the sensory strip, which are just either side of the central sulcus, and a little bit to the front of that with eye movements and other things. Then the executive function, the planning, is a little bit to the front of that, and the emotional brain is further round underneath orbitofrontal lobe and anterior cingulate gyrus. There isn't an absolute separation between those areas. They act on a continuum, and if you ever look at a brain, you know, a real brain in front of you, you'll see that there aren't absolute distinctions. So my take-home message is, maybe these distinctions we make, the three areas of Huntington's disease, are an artifact of the professions involved in the illness rather than a real manifestation of what's happening in the brains of people with Huntington's disease. And that's my plea for Huntingtonologists. Okay. I'm going to talk a little bit about misdiagnosis, because in the time I've been seeing people with Huntington's, we've had a variety of misdiagnoses. And these are the sorts of things that people are misdiagnosed as, commonly psychiatric things, actually, these days, psychiatric diagnoses. One of the problems here is that I think because mental health services and physical health services have existed separately, when we take histories from people, if we say to somebody, for instance, have you got a family history of anything, and they say, I've got a family history of depression, or my mum had schizophrenia, then we think, oh, that's nothing to do with neurology, that's psychiatry, so we'll just forget about that. But actually, that could easily be Huntington's disease. It's quite common, actually. To give you an example of that, I had a patient who I went to see who was an old lady, or she was about 80, I think. She had an initial diagnosis of Alzheimer, and the local old age psychiatrist went, it doesn't look quite right for Alzheimer, this case. She hasn't got the predominant memory loss. She's got a little bit of motor disorder, some dystonia. Will you go and have a look? So I went to have a look, and I said, sure enough, this looks like Huntington's disease. So the question you would ask then is, anyone in the family with anything? She said, well, my dad, I think, had something like chronic depression. He was in an asylum for a long time. And she said, and then there's my brother. He's got schizophrenia, chronic schizophrenia. So I said, oh, well, where's your brother? And she said, well, it's funny. He's been sectioned. He's in the ward down the corridor. So I went to see him. This is a man. He's had a diagnosis of schizophrenia for 25 years. Initially presented with psychosis in his 20s. And then after he'd been treated for about 10 or 11 years, he started to get motor disorder, and everybody said, oh, that's the drugs that do that. And then after a few years later, he started sitting in a corner and chain smoking all the time and not really doing anything. And everybody said, oh, that's what happens in schizophrenia. They get burnt out or negative defect state or whatever they call it. But of course, that could also be a rather protracted history for Huntington's disease. This story has a slightly sad ending because I thought I was being very clever, and I went to see the ward, and I said, well, look, you've got this guy, you've been treating him for Huntington's disease, for schizophrenia for the last 15 years. I think he's got Huntington's disease. And so they did a test, and they decided, yes, sure enough, he had Huntington's disease. And then they said, well, we can't look after him any longer because he's got a physical illness, not a mental illness. Even though he hadn't actually changed clinically at all, they said, well, we're not skilled to look after people with this sort of condition. And so they discharged him. So what I initially started off, for me, thinking being clever, ended up being to the detriment of the patient. Here's some things to watch out closely for when you're looking for the diagnosis of Huntington's disease. Firstly, family history is really important. You should ask for a family history of both neurological and psychiatric disorder and sort of chronic disorder that might involve institutional care. So broaden it right out. Also be aware that the person you think is your father might not necessarily be your father. And it's sometimes worth having a look around that, and that includes your uncle. The other thing to bear in mind is not everybody knows what Huntington's disease is as compared to other sorts of neurological disorder. So if somebody came to sit down in your clinic, as somebody did with me, and I said, anything in the family, and he said, my dad had Parkinson's disease, well, normally if you get a family history of Parkinson's disease, you don't think anything of it really, particularly. But then after a while, when we went back and we revisited it again, he said, oh, well, he had Parkinson's or Huntington's or one of those sorts of conditions. And to him, he wouldn't have seen the difference. But of course, if you're sitting here, it seems to be the world of difference. But to him, it didn't seem different at all, really. Be wary of atypical features. Now, I suppose depression is a syndrome, so an atypical syndrome is an even more dangerous place to go. So people say they've got depression without depressed mood, for instance, but they've got all the other features. You know, they've stopped functioning socially, they've withdrawn, they're not sleeping well, they've lost weight, but they don't apparently feel to be depressed. Now, sometimes people call that atypical depression. So, but I would say always be wary of atypical syndromes. I've already talked about not calling all movement disorder tardive, and there's another thing that I think we as mental health professionals do sometimes, is that we relabel movement disorder as behaviour disorder. So if somebody's got chorea, we sometimes say they're a bit agitated or a bit fidgety, or they can't sit still, or we imply a sort of associated mental state rather than saying, actually, they've got chorea. We say, well, they're fidgety, they can't sit still or something. Okay, these are some of the other things that we've seen people get diagnosed with. In a child group, these neurodevelopmental disorders like Tourette's, ADHD, conduct disorder, there have been a few cases of children with HD who've been diagnosed initially with those sorts of conditions. Then there's a bunch of people who I think are probably getting apathy and problems with multitasking that have been diagnosed in the chronic fatigue syndrome ME box, and I've seen 4 or 5 cases like that who've had that sort of a clinical picture for a number of years before it turns into more obvious HD. Obviously, good history taking will help with that. We must never forget the age of onset is broad, so very young people and very old people can have their first manifest things. Okay, a little bit of new data for you. I think David this morning presented data from Susan Folstein, who looked at DSM-3 diagnoses. Our PhD student, Jenny, has been interviewing people with an inventory called the SCAN. And actually, when she interviews people, the SCAN allows you to take into account the context. In other words, when you're making a diagnosis of depression, according to the SCAN, you can take into account the fact that the person's lost weight, then that might not necessarily be due to depression if they also have Huntington's disease. So it sort of helps to get around that bias, if you like, or potential bias. And these are lifetime prevalences in a group of people with Huntington's disease. And I suppose, well, depression and anxiety we knew are strong contenders. Again, to highlight what David said, OCD, pure OCD, and that is unwanted thoughts or actions that you actively try and resist, are no more common than you would see in the general population. And there's more and more evidence that suggests that. And we used to think OCD is part of Huntington's. Actually, it isn't. Perseveration is part of Huntington's. Getting stuck on something is part of Huntington's. But OCD, which implies this thing that you don't want the thoughts or the behaviours when you're actively fighting them, actually isn't particularly common at all. Then, of course, there's this condition which we didn't look at, but perhaps we should have done, which is personality change due to a general medical condition. Some people call it organic personality disorder, and it's a sort of catch-all for the types of cognitive problems that people with HD have: difficulty in planning ahead, difficulty in pursuing things to a goal. I mean, this is almost universal in HD, depending on the severity of it. I would also say there's a bunch of mental symptoms, and Jenny found this, that can't be readily classified, particularly people who have transient low moods. So in other words, people will meet, if you like, the criteria for depression for, let's say, a week, and then they'll be fine for 3 or 4 days, apparently without any problem at all. Then they get this criteria for depression for another week. Now, that doesn't really fit in with what we think of as clinical depression. It's something else. It's some other way of looking at it, and maybe it's just a different beast altogether. We also sort of carve these types of symptoms up, and other people have done this, including David's group. And again, we're roughly getting to these idea of 3 different sort of factors in behaviour in HD. One is irritability, apathy, poor planning, perseveration, and I suppose you might call that a dorsolateral prefrontal cortex sort of a group. One is a depression anxiety group, and then a very small but distinct group of psychosis. I think that some of that might be psychosis in the context of delirium. I don't think it's a big group, but it seems to be distinct. Okay, I'm not going to go on to this because David really went into this morning, only to say, why might people with depression, with HD, be vulnerable to depression from a brain point of view? This is my way of looking at it. It's a bit sort of simplistic. I think it's probably 2 factors and maybe a 3rd factor. The first factor is, of course, people with HD have more life events. They lose jobs, they lose partners, they have life-threatening illness, so they've got that. So they've got big life events. Secondly, when you have a life event, you use your coping strategies, which is to think and plan and work out plan B. And thinking and planning and working out plan B is what you use your dorsolateral prefrontal cortex and its connections with the striatum for. So if you've got big life events, but your plan B bit of your brain just doesn't work at all, then that's what's going to make you vulnerable to depression. And I think that's my sort of simplistic view about why people with Huntington's are vulnerable to depression. The other thing is, of course, that you may be on some drugs for your career which are really worsening your mood. So it might be a combination of those factors. I don't want to go into this very much, except to say, if you're going to use a screener for depression in Huntington's disease, then probably the Hospital Anxiety Depression Scale, the depression side of that is probably the best one to do. There is a scale called the DISC scale for people who can't communicate well. And we know, David said it and I'm saying it again, these vegetative symptoms, the sleep, the appetite, the weight loss, aren't very good discriminators. Here's some of our data on suicide. These are lifetime suicidal ideation and intent. And this again is from Jenny's PhD data, which shows the majority of people don't get suicidal ideation, but there's a lifetime ever attempted suicide rate of 14.5%, which is considerable. Right, David's covered that, and the only thing I would add to that is, do you need your anti-chorea drugs? Is chorea really a problem? Do you really need the tetrabenazine or the risperidone or whatever it happens to be? It might be that other things you can do, like managing another symptom like a swallowing problem, might also be therapeutic, because that might be the thing that's triggering it off. Okay. David mentioned irritability, and this is my definition of that. And these are the sorts of things that will happen. I just wanted to take a little bit of time to think about what might be happening in the brain to make a person irritable. This is, again, my simplistic view of what might be happening in the brain of somebody to make somebody irritable. So I was thinking about what makes me irritable, and we all get irritable, and what makes me irritable is if I'm asked to do too many things at once. And that might be a lot of things, because I'm quite good at multitasking, but if everybody's got a threshold for that. And when I'm asked to do too many things at once, the first thing that happens is I get anxious about it. And then when I get anxious about it, if it's really bad, I'll probably have a bit of a snap at somebody, and probably more likely to do that if they're one of my nearest and dearest than if it's somebody outside the family. That's the way it goes. So I'm trying to think of irritability in HD as the same process, just with an incredibly low threshold, as low a threshold as you could possibly imagine. And so it's really difficult, I think, because we take multitasking so much for granted in our life. It's really difficult to imagine a person who really just couldn't do even more than the most simple bits of multitasking, like having a couple of people round for a cup of tea and some cake, or to answer the phone when somebody's asking them a question. Just something quite simple, or even to keep shaving or eat your food while somebody's asking you something. So it might be exactly the same thing that makes us all irritable, but just the threshold is right down on the floor. So the way I look at it is you've got this low cognitive capacity, especially for multitasking or for complex things. That's going to make you anxious when you put into the situation. Then the next thing is you've got disinhibition too. So that bit of the brain that says, hang on, Hugh, you might be feeling irritable now, but it's probably not the right time to do it because the following things might happen. That bit doesn't kick in either. So there's two steps to it. I think the first is the lack of multitasking, and then the second is the lack of inhibition, and probably it's mediated in the middle through anxiety. There's a little bit of work on this by a Dr. Nimagada who published last year on this subject. I think it's quite a nice way of understanding it. Okay, David talked about this, so I'm not going to go in this in detail. Something that became apparent to me in talking in different parts of the country is how you get treated for irritability really depends on your postcode, I think, at the moment. Because different centres, this is not necessarily a bad thing, but different centres have their own sort of favourite things that they go with. And probably that's okay, because they probably all roughly do similar sorts of things. They probably all roughly work. It's just people get familiar with using one set of medicines rather than another. And so what you get may depend on where you live. I'm aware that I haven't included olanzapine in this group, and I just want to say a little something about olanzapine. So olanzapine can be good for irritability. It's a mood stabilizer, and unlike most of the rest of those, it can stimulate weight gain, which could be useful. Right. The cognitive thing, I think I've talked about quite a lot already, but just to really reinforce this multitasking thing and how problems with multitasking can occur very early and very subtly. And I think the best description I had of a multitasking problem at the very earliest stage was a lady I had who was, I think she would have been in Sarah's term, a pre-A, HD, so very pre-manifest. She said she started, the first things that she noticed, which was way before motor onset, probably about 10 to 12 years before motor onset, she was a primary school teacher, which of course is, your multitasking par excellence, isn't it? She said she lost the eyes in the back of her head. Everything else was working completely fine, but as a primary school teacher, she lost the eyes in the back of her head. And I suppose that's probably the most sensitive measure you could have for a very early, subtle cognitive problem. Just a word of advice for people, which is if you're testing cognition with people with Huntington's disease, your standard mini mental state examination isn't very good because it's got really big ceiling effects. So mini mental state is scored out of 30. You could get 28, 29 out of 30 on a mini mental state examination and be really, really impaired. So I would just chuck it out the window, actually, and not use it at all. And be governed by what you can see people do and not do in the real world, I think. There isn't really a treatment for cognitive impairment, although I think probably if you look at mice models, probably things like environmental enrichment could really help cognitive impairment if only we could prove it, and maybe even aerobic exercise might. So those sorts of things I think might in the future turn out to be good for cognitive impairment in Huntington's disease. And of course those are great things. If we can prove them, those are things you can take to nursing homes and say if you want to improve the cognition of your HD people, you need some environmental enrichment and some maybe physical exercise if that's possible. Other ways of improving cognition are actually changing environment. So for instance, I had a chap who had appeared to have quite poor cognition, but he was living in a very high stimulus environment. He was with his wife and his two daughters and they were quite full on, and he was getting very irritable and overloaded with things, and he was performing cognitively quite poorly. Now, he and his family made a decision that he was going to move into a flat down the road, about 100 yards down the road, and live by himself, and sort of reduce his overall cognitive load. But when he did that, he found that his level of function and his apparent cognition improved, maybe because he had less extraneous tasks being poured on him. Now, I'm not advocating that everybody should live separately from their partners, but in this case, it really worked. It really worked. And you sometimes see it post-stroke as well, that actually living on your own, managing your own cognitive load yourself, might actually be really helpful and really therapeutic. Interesting idea. Okay. I don't think I'm going to talk about that because people need to have a cup of coffee. I would only just say I do have a problem with the way that HD's been abandoned, if you like, by a lot of psychiatric services. Stoke being a good exception, of course, and long may that continue. And that's initially down, I think, to the good work of Ken Barrett and then George since then. I'm really worried about these times when people go with Huntington's and a bunch of other things with mental disorders, and community mental health teams say we can't do that because it's physical, not mental, even though the symptoms are mental. That seems to me philosophically wrong and also ethically wrong, but we're going down that direction already. And so if you work in mental health teams, I'd strongly suggest that we don't go down that way. But also, even though we've sort of closed the asylums and theoretically these people have just gone out into the big wide world, what's actually happening is the new private asylums are cropping up. And here are some of them along the back of this room here today. So the demand hasn't gone away. It's just the NHS isn't fulfilling it. So it's cropping up in other ways, not necessarily badly, but I think the health services sort of, the mental health bit has sort of washed its hands of them a little bit. Okay. The other thing is that the legal profession haven't, because all these things like the Mental Health Act and Mental Capacity Act still apply to Huntington's disease if they have mental changes. So it seems to be symptom-led rather than this spurious idea that physical and mental are separate on a causatory level, which doesn't hold any water. Finally, to say also that people with Huntington's disease can be sectioned under the Mental Health Act if it's appropriate. And this can be a good thing because it can protect their rights because they have access to the mental health review tribunals, unlike, as I've seen before, people going from home to nursing homes and then having what we call a dole slapped on them. You probably know what I'm talking about. And then they don't have access to a mental health review tribunal. They don't have access to Section 117 aftercare, which means you can't force the local authority or the health authority to pay for their care. And I've seen people, because I work for the official solicitor, I've seen people that have had that happen to them completely clandestinely and haven't had any access to any legal recourse for 4 or 5 months after detention. So I think we've got to worry about the over-reliance on the Mental Capacity Act. And I think the latest ruling from the court is that if there's a question of detention and there's a question of is it the Mental Health Act or the Mental Capacity Act, really the courts now rule that you should really use the Mental Health Act because that protects the patient better. It protects the patient's rights and it protects the patient's aftercare as well. Okay, that's my politics out of the way. So finally, to conclude, mental state changes are common, and I hope I've sort of illustrated to you how mental state changes, physical changes, and cognitive changes are all of a piece, and they all predominantly live in the striatum. They're the main source of difficulty. They're caused by brain changes, more life events, and of course some medications. Some are readily treatable, and 2 or 3 other speakers have mentioned that, but there's a demand for, if you like, Huntingtonologists who can treat the whole of the illness rather than one little bit of it, because that's not helpful to the patients on the whole. Thank you.